Good morning or good evening, depending on where you are. My name is Donny. I'm the Orbis volunteer faculty and also the Chief of Pediatric Ophthalmology here at the Children's Hospital and Medical Center in Omaha. And also I'm an associate professor at the University of Nebraska. Thank you very much for joining us today. I think this is going to be very entertaining, educational, but informative talk. It doesn't really particularly, is not anything specific about pediatric ophthalmology, but I'm going to be talking about 3D technology and how it actually impacts us in our field. So the objectives, I hope everyone can hear me okay. Okay, so the history, first I'm going to talk about the history of eye muscle surgery, and then just briefly talk about how we actually do it. I'm going to show you a video, and then I would like to share my old invention, the saw groove hook, and then talk about all the new inventions that I've actually been working on since in this year. And then financial disclosure, the saw grooved hook was actually developed a few years ago, and all the proceeds go directly to Orbis. And all the new inventions, our university and I own the patents, and none of the products that I'll be discussing is in production at this point. So before I start, I would like to have an idea of who I'm actually talking to. This webinar is something that I'm not very familiar with, but I would like to have the general audience some participation. So if you could actually answer this question, what is your profession? So if you could just click one of those, and if it's others, please type in what field, like how you're related to ophthalmology. Lawrence, how long should we give?
We'll give them about 10 more seconds.
Okay, sure. Okay, great. This will help me to taper the talk, depending on the who the audience is. Okay. Okay, perfect. So we have some pediatric ophthalmologists, a general ophthalmologist, and we have some others. Okay, and I want to see what the others are. So Q&A, and then is it answer right here? Answer by text?
So there's two chats under more. So we have a medical student with ophthalmology interests and someone also in medical retina.
Okay, perfect. Thank you.
Yep, and oculoplastic.
Perfect, perfect. Okay, I would like to just briefly talk about the strabismus. The word strabismus is originally started from it's a Greek term. It's from the 1600s, and it actually came from strabismus, and it actually means crooked or twisted. So here's a patient with esotropia, and back in 18th century, English surgeon John Taylor attempted to perform the strabismus surgery by cutting the conjunctiva, but it just wasn't, it was poorly documented, so he didn't get the credit. In 1838, Louis Strohmeyer proposed cutting the extraocular muscles, but as far as we know, this was not performed till 1839. So the first surgery that was performed on a muscle was Johann Friedrich Dieffenbach from Germany, and he actually performed the first official myotomy or tenotomy. And so he actually had an instrument that was almost like a sickle, and he would just simply go and cut the muscle. And of course, the success rate of the surgery wasn't very high because there was no way of controlling the amount of the correction. So patient with esotropia would end up with a large exotropia by simply cutting the extraocular muscle. And this actually went on for a while till 1922. Around that time, Jameson substituted the tenotomy, or where you just simply cut the muscle, by graded muscle recession using a Jameson muscle hook. And this was only possible because around that time, sterile sutures were developed. It was a catgut that was developed in 1906. With the iodine, not betadine, iodine treatment. So that actually revolutionized the strabismus surgery. And here is a diagram of an eyeball with the extraocular muscles that's attached to the eyeball. And we typically place the muscle hook underneath the muscle and raise it, and then we place the muscle suture just anterior to it. So I'm going to show you a video of what this. I'm going to show you a video of what this this will look like. So Lawrence, can you see this okay?
You're going to have to reshare your desktop for us.
Okay, just a second. How do I do that?
It was the same way you pulled up your slides. So share screen, desktop.
Okay. Sorry about this technical. You know, share the desktop. Can you see my screen right now or no?
We see you. You have to click on share screen right next to Q&A.
Where's your Q&A? Can you see it?
It's on the Zoom bar.
Is that okay? And then
we don't see your screen yet. Now we do.
You do? Okay.
Yep. So then you can just open the videos.
Okay. Good. Thank you.
Yep.
All right. So this is a video. So this is actually a video that was developed by our UNMC 3D team. So we would actually place a muscle hook underneath the muscle, and then place the needle just anterior to it, and then secure the muscle in this fashion. And obviously there are many different techniques that's available. And once you secure the muscle, we actually cut the muscle off the globe and completely separate. And then we would rotate the eyeball, straighten it, and then we would secure the muscle so many millimeters posterior and pass the needle through the original muscle insertion, and this is what you end up with. And of course, this is called the hangback technique. So, and let's go back to the PowerPoint talk. Okay. Now, the second question that I want to share is that, do you perform strabismus surgery? Yes or no? Okay. Perfect. Okay. So I hope that video actually demonstrated what we do. And we're gonna skip the next. We're not gonna take a poll for the next question. So what are the most difficult types of strabismus surgeries? Anything that these are some of the difficult cases that we do: Graves' disease, Mobius syndromes, anyone who actually had previous muscle surgeries, reoperations, and muscle surgeries around the sclerobuccal procedures, congenital fibrosis syndrome, and muscle surgery following traumatic scarring. So these are some of the cases that we actually perform that are just very difficult. And for those who actually perform the strabismus surgery, I do know, I mean, I'm pretty sure they share my concerns. And so what do you do in these difficult cases? And you don't have to type in the answers because we don't have, we actually have many who are not in the pediatric ophthalmology field. But in these difficult situations, I do have to tell you, it is extremely difficult because these muscles are under great tension, and these muscles are scarred or under great tension, and it's actually very difficult to place the muscle hook underneath those tight muscles because there isn't a lot of space. So there are 5 unique problems to these tight muscles. So first is that because the eyeball for example, in this particular case, the superior rectus muscles will be very tight, and it's hard for me to actually rotate the globe to actually visualize the superior rectus muscle to hook the muscle. And second is that these muscles, because they were tight for so long, it would actually result in adhesions of the tendon to the sclera. And so passing, even if you isolate and find that muscle, placing a muscle hook underneath is sometimes actually almost it's impossible. And then even if the hook was somehow passed through, the passing a needle just anterior to the muscle hook to the tendon can be very dangerous because there isn't a lot of space between the sclera and the tendon, as you can see here. And then and on top of that, to make things worse, the sclera is typically extremely thin underneath underneath the tendon because of the chronic pressure and ischemia. And so the risk of scleral perforations and resulting in potential infections or retinal detachment goes up dramatically in these patients with very difficult cases. And as you can see here, very thin in sclera. So this can be extremely stressful. So to address these concerns, various grooved muscle hooks have been developed. We actually have Dr. Ken Wright and Dr. Ed Wilson. There are actually various grooved muscle hooks that have been developed. And this is my version of it. And it's got 5 unique features. First is that I've made it very skinny. It's a 0.8 millimeters thick versus a 1.2 thickness in a Jamison muscle hook. And then also I made it shorter. So it's the length from here, the length of the muscle hook is 8.5 millimeters versus a 12.5. So I made it thin so it can fit through a tighter space. And also I actually have a horizontal bar plate that's 2.5 millimeters with a groove that's 0.8 millimeters to guide the suture needle passage. So what that means is that when you place a muscle hook underneath the muscle or the tendon, this is the cross-section view. This is what it looks like. So it actually has a groove right there. So you can actually pass the needle right through that groove without having to worry about potentially perforating the globe. And then fourth unique feature is that the knob. Actually, I made it very sharp and it's pointy. So this is actually important because it actually helps me to find that plane on the space between the tendon, the space between the tendon and the sclera, and then I use that sharp knob to dissect and separate the two tissue plane. So I use that instead of Westcott scissors and doing it blindly, if you will. Using this knob, I actually use it to dissect, to separate and create that space. And the fifth unique feature is that I actually bent the handle. So why is that important? Because many times after you place the muscle hook, the nose actually typically gets in the way, like either the nose or the orbital rims get in the way, and it actually prevents it. So the muscle hook actually gets in the way of me visualizing the tendon. So by bending it, you can actually see that it's actually out of the way. You can actually, the nose doesn't get in the way, so the muscle hook won't be sitting up this way. It's actually bent, and so it's actually lying flat. So after having developed this muscle hook, these tight, difficult cases actually became much less stressful. So and so that's what I've been using. So, and I wanted to share with you, what have I learned from this experience? First of all, the manufacturers, and I've actually worked on this muscle hook for about 10 years. This actually started way, way back, and it took me 10 years to develop this. And I realized that it's actually hard to find a manufacturer because they're not interested, because these are small number of cases that actually require special instruments. So we're not talking volume. So it's and it's for a specialist. And then also, once you come up with an idea and they make it for you, when you try to make a revision, it's impossible. It's actually very difficult. And then multiple revision is basically just, you just can't do it because it costs the manufacturers too much money. And then it's very time consuming. Like I said, it took me 10 years. And then by the time you develop it, maybe it's too late. It's like someone else actually had developed it. And then not to mention the cost. And like I said, people, I realize that people who invent things, you really have to have I have to have passion for it. It's like it just doesn't pay, and it just has to. So after this experience, and I told myself I will not do this again because it was just too painful. But then I had a Dory moment, meaning I just forgot that actually it was so painful, and I developed a desire to develop a new muscle, new needle driver that. And what it is that in certain situations, we would have to place a needle in a very awkward place where the traditional needle drivers you just can't get to that point. And this actually happens not just to pediatrics, but for people in oculoplastics, people in retina, and it's very awkward. So what ends up happening is that you actually have to hold the needle holder. You actually have to hold the needle holder with your non-dominant hand and switch over and use it this way, and then try to place it. But then it just becomes very uncomfortable. So I wanted to, and I'm going to say, I'm pretty sure that most of you actually have experienced this before, so I'm not going to take this poll. So I wanted to come up with a needle driver that looked like this. Looks just like that. So I can place a needle in an awkward places that are difficult to place posteriorly. So we came up with a drawing, and this was actually drawn by a very talented student, high school student. She's now in college, Elise Morgan, and we actually came up with a nice drawing like this. And then I went to the manufacturer and said, please make this instrument. And they said, it's impossible. They said no. And the reason for that is that because of this sharp 90-degree angle, it will not close properly. It's just not going to work. It's impossible. That's what I was told. So, and I don't know if you remember, this is actually one of my favorite slides. I actually got this from Dr. Scott Oliski from Kansas City, and he's get your feet off my desk and get out of here. You stink, and we're not going to buy your product. I feel like I hear this all the time from my manufacturers. And this was actually quoted by Atari president Joe Keenan to Steve Jobs. And of course, I don't have to tell you about Steve Jobs. He actually have built one of the most successful companies ever in history. So, and he's, in many ways, he's inspirational. So I wanted to tell the manufacturer that it can be done if you put your mind to it. So using a 3D printed prototype, we actually have a 3D makers here at the University of Nebraska. We actually we converted the digital format. We converted the image, the art drawing, into a digital format, and then created the instrument. And this is actually what it looked like. And you could actually see this. We actually made this, and the manufacturer was absolutely correct. We could not close the tip. It just didn't work. So we actually had to make many modifications to the tip, and after 3 alterations, we were able to create a plastic design that actually worked. And so this was the final product. And then we actually went to the manufacturer and came up with our first titanium needle driver. This is actually what it is right here. And this is what it looks like. So, so now we actually use this needle driver on an eye model, and then we actually tried it. We actually used it on a patient, and this truly made the surgery safer because I didn't have to switch the instrument from my dominant to non-dominant hand constantly as I'm performing the surgery. So this was actually shown on an Orbis airplane. This is our Orbis Flying Eye Hospital where we actually performed the surgery inside. And I was actually in Orbis trip to Qatar back in March of 2017. So these are wonderful doctors from actually not just from Qatar, from the Middle East, and watching the surgeries. So they were actually able to see me actually using the instrument, using the instrument and an eye model live. actually, and I was able to demonstrate how this instrument worked. And so this was truly groundbreaking. And then this was only the beginning. So after that, I actually looked at the syringes. The current syringes, we actually have, we use these syringes actually that were developed many, many years ago. And these syringes, the problem with that in eye surgery is that, as you can see, and I'm holding the instrument, and then my index finger is actually out of the picture here. It's actually way out there, and you're trying to push that plunger, but then you actually have to, in many times, we actually have to, inject 0.1, in some cases 0.01 cc. So it's actually very hard to control exactly how much to inject. And it's very clumsy. It just doesn't work. So especially for ROP, I typically use 0.025 cc, and trying to do this can be very, very difficult. And here I am actually holding onto the syringe, and my fingers are typically not long enough to actually reach that plunger to inject, and while the patient is moving. So I usually have my nurse push that plunger for me as I'm holding on to the syringe very firmly. And this, I'm pretty sure many of you actually would concur, can be a very, very difficult situation. And this is actually different than adult patients who are cooperative, who actually follow instructions. But when you're doing this on a premature babies, it is truly difficult. And trying to inject that exact 0.025, even if it's preloaded on a syringe, it can be very difficult because it's unstable. It's hard for you to hold it firmly with 3 fingers, and then having holding it with 2 fingers, and then trying to push that plunger with 1 finger. So after many, she's actually my medical student, Helen Song. She actually helped me along with the many others, and we actually came up with the first Nebraska precision syringe. And this is actually exactly what it looks like right here. And what it is that it actually has the plunger is actually attached to, it has an attachment. So you could actually use your finger to inject. So you could have all 3 of your fingers just right in close proximity, and then you could aspirate and you could inject. You could inject, so here, you could aspirate and inject. So, and potential use of the syringe can be immense. In emergency room ICU, diabetic patients who are trying to inject that 1 or 2 units, or operating room, for us, and then post-op, pre-op meds, and animal research and lab research. So this is actually, we're actually working with various manufacturers. We're trying to find a manufacturer who can actually produce this. And then Botox. This is another field that actually can be very difficult. So for Botox, been around since 1980s with the help of with Dr. Scott's original paper. Here, what we do is that we isolate the muscle, and then we inject the Botox directly to it. But the problem is that current problem is that there's always a risk of perforation, and it does actually happen. And the reason for that is that as you inject the needle into the muscle, if you don't mind, you're doing it somewhat blindly. You don't know exactly where the tip is. So that's the risk of the perforation. And also the Botox can actually get the diffusion of the Botox can actually result in various side effects, including ptosis. So to address this problem, a new Botox forceps is actually being developed, and this is where it actually has a actually, I don't have it in front of me here right now. So this is exactly what it looks like. And this is a forceps. It actually has a tooth. And then it actually, when the tooth is closed, it actually forms a groove or a tunnel. And then the needle can safely be injected into that tunnel. So what it does is that when this forceps is actually engaging the muscle actually gets clumped and it actually gets encapsulated within that tunnel. And then the needle can be injected into that tunnel. And because of the tooth are meeting at the bottom, it actually protects the sclera. So, and it actually has a broad forceps base of 7 millimeters at the base, and then forceps tunnel opening is 4 millimeters in diameter, ensures that the muscle is consolidated in a confined space. And the injections into the tunnel provide safety and avoids a risk of perforations. And then it actually, I actually curved it significantly. I curved it so that it actually, the handle gets out of the way for better exposure, and it's actually currently being made. And also the glasses. These glasses, the current problem with glasses that kids without ears, like with microtias, they walk around with the glasses that are just completely mangled, and they're not sitting properly. And of course, when they're not looking through the optical center, they still can't see. So with the help of with the help of Mr. Hermsen, we actually made our first Nebraska microtia glasses, and this is actually being this is available throughout the world. And again, I have no financial interest in any of this. And basically, it's basically what it is that it's a special type of plastic that actually wraps around the top of the head, and it's the heat, your body heat actually helps to conform to the shape of your head, regardless of the shape of the head. Like let's say you have a microcephaly, macrocephaly, plagiocephaly. This actually conforms to the shape of your head and looks just like that. And so this actually has gotten a lot of publicity with the help of the news, and I'm pretty sure, I don't know if you've actually I think it's a Today Show, or I think it's been on TV. So this actually and this adapter right here, we actually provided to the patient at no cost around the world, so they can actually contact us and or contact me, and these glasses can be provided. These adapters can be provided at no cost to any of the patients. Now, focusing on us, actually, one of the things that I would like to focus on, one of the things that I have great interest is actually ergonomics. Not, because, with the shortage of doctors, with increasing the population, we need to stay healthy. We need to practice longer, but unfortunately, our postures are horrible. It's not just for the pediatric ophthalmologist, but this includes retinal surgeons as they're doing the buckles. It's actually plastic surgeons, dentists, urologists. As I look around my colleagues around the hospital, I realize that they are just they're actually we have a great risk for upper neck and back injury, and actually causing many people to retire early. So, and with the surgical loops, and if you keep your head, if you actually try to keep your posture in a perfect vertical posture, you can't see the surgical field because you're looking straight ahead. So, and I've actually tried every single surgical loops that's really out there that I could find, and nothing really worked. So I wanted to actually address this problem, and we actually made the surgical loops with a 3D printer, and we made some modifications. And after a few modifications, we came up with the first Nebraska surgical loops, and this is kind of like what it looks like. And this surgical loops is if you look, with the current surgical loops, it actually induces a bad posture. Looks like this, as you're working on an eyeball or just any type of surgeries. But with this surgical loops, it actually, it's much lighter. The material that we worked with is actually much lighter, and so it's less pressure on your nose. So if you have a flat nose like myself, it actually doesn't slide down And it's much more comfortable because the weight is actually distributed throughout the head evenly. So you can't even feel it. And also, the correct head, and also it actually allows you to keep a posture that's completely straight up and down. And the way that it does that is that it actually has a prismatic effect. It actually has a prismatic effect. So what I mean by that is that even though you're looking at an image, this way, it has, because of the prismatic effect, it actually moves the image that's down here further out. So, and I'm going to actually talk about that in just a little bit more. And I'm actually trying to confirm that it truly relieves the pressure. Using the various types of biomechanics using surface EMG, and that's what we're working on right now. And so this is actually the, and I had to make some modifications to these surgical loops with the help of manufacturers, and this is actually made by Q-Optic. And again, I have no financial interest. So if you look carefully, this is actually what it looks like right now. So if you look, the angle from the surface, so these glasses are actually has a curvature, a base curve that's very steep, and then the lenses, the bifocal portion is actually pointing almost straight down. So this angle right here is almost 110 degrees, this angle here. So as you put this on, and then and this is actually what actually induces the prismatic effect. It's the base curve and also the location of the loops. And then the back portion of the temple portion of the glasses, actually we made modifications. So this is actually what it looks like. And so instead of having this cumbersome headpiece, it actually looks much more fashionable. And with this, I can be working here. You can see the various models out here. You can be working on something right underneath your nose, but that image would get displaced further out so that you could keep your head posture completely up and down. And this is actually what I actually have been using after I developed it. And right now we're working with the manufacturer to fine tune it. And this personally actually completely eliminate all my neck and back pain. And this is actually the product that, and we're continuing to make modifications. So, and we actually changed the back piece to look like that. And the good thing about this is that you could put this on, and then you could adjust it from the back, like this. You could adjust it. It actually, this piece right here slides back and forth. And then after you're done with the surgery, you could just wear it around your neck. So it's very comfortable. And because of the angle, it actually sits very perfect. It sits actually very comfortably, and it prevents the sliding of the surgical loops down further your nose. Okay. So it's still a work in progress. I'm continuing to fine tune it with the help of the manufacturers. And lastly, shaken baby syndrome is another topic that I've great interest in. Unfortunately, here in Omaha, Nebraska, we have the highest prevalence of shaken baby syndrome in the United States, according to the Omaha World Herald newspaper. So we actually see probably I see a case of shaken baby syndrome about one a week. It's actually so it's a kind of sad cases, and it's the most common cause of death due to child abuse, and it is suspected that we have about 5 children per day that die from this condition, and then it's the most common cause of traumatic death in children under the age of 12. And even if you survive from the shaken baby, many of them actually have a permanent sequelae of forms of motor, intellectual, visual deficits. And then the biggest problem is actually ignorance, public unawareness. This is something that's very well known in the world of ophthalmology, but outside of the world of ophthalmology, it's actually not, people don't know. As a matter of fact, there's certain physicians who actually do not believe that this condition actually exists, even now, even today. So, so I was thinking, what can I do with our current technology, with the 3D printers, 3D images, virtual realities? What can I do to educate the general public awareness? So what we're doing is that we're working on a virtual reality to simulate abusive head trauma, to demonstrate the live retinal hemorrhages to educate the general public. So here, let me just show you. Just a second. How do I stop and then go to the?
So Dr. Saw, you're gonna have to reshare your screen.
Okay, okay, share.
Share your desktop like before.
Share, okay, good. Oh, I see, okay.
And then you can pull up the video. Just exit out of your PowerPoint.
Okay, got it.
So you have to reshare one more time.
Oh, I have to, okay, now I understand. I have to redo it, okay. Can you see it now?
Yes, we see it.
Okay, perfect. So here, we actually have, we're in the works right now with our iExcel department at UNMC. They actually specialize in 3D and virtual reality. So here we have an image of an eyeball that's being shaken at 0.5 to 1 hertz. And we're seeing various hemorrhages in the back of the eye. And as you shake this image, as you shake further and go up to 2 hertz, you could see increase in amount of retinal hemorrhages. And then as you go up to 3 to 4 hertz, that's when you will see a significant increase in retinal hemorrhages and potentially retinal detachment and retinal schisis. So what we're doing is that we're creating a virtual reality where our audience can actually wear these special glasses and they can hold on to the image and they can shake it at different speed and they'll be able to see the retinal findings live. So, okay, I'm gonna close this. And then, so can you see me okay?
Just share your desktop one more time so we can see your PowerPoint.
Is that okay?
Yep, just pull up your PowerPoint and then you should be good. Yep.
Perfect. All right. So, and then also we're developing a computer finite element model to determine the exact locations of the stress points. And also we are working on animal models to determine the vitreoretinal traction during shaking. And we're incorporating this into our virtual reality image so that as they, to determine exactly how much force is being applied to the eyeball at various frequencies. And then as I shake the eyeball at various frequencies, you can actually see the changes within the retina live. So this is a great way to demonstrate to general public of what can actually happen to the retina, and we can confirm it and verify it through our computer generated model and also the animal model. We can do and support it. So in summary, actually I just have a few more slides. What does Orbis mean to me? Actually, I've been with Orbis for 17 years. And I actually grew up with my mother when I was young, I actually grew up with my mother and my brother, and it's just been a wonderful experience. We had a very modest living condition, but it was just wonderful. But the problem was that one of the biggest obstacle was that my mother actually had an eye problem that we just could not get it addressed, for financial reasons, for many different reasons. So I told my mother that I actually wanted to be an eye doctor. I wanted to be the best eye doctor possible and then help her. And then this was actually her quote. She said, that's like grabbing a star from the sky, and sky is truly our limit. And the reason I love Orbis so much is that, what do I believe? And I actually thought this through, and the Orbis actually truly changed the way I look at things, because even truly the sky is not our limit. As you saw, we actually can, through this webinar that we're doing right now, and through this airplane with the lecture rooms inside the plane, we can actually give these type of lectures anywhere around the world. And this type of information can be disseminated very quickly. So that actually excites me a lot, and that actually, encourages me to come up with more things that can actually help our patients and help us. So I truly appreciate everyone paying attention for this for the last 40 minutes, and I would like to entertain any questions or thoughts. Please type in your questions, and I'll be happy to answer any questions for the next few minutes.
Thanks, Dr. So you can go ahead and stop sharing your screen so we can see your whole face.
Sure.
We did get one chat in. If you want to pull up chat, or do you want me to read you the question?
Let me do chat. Okay.
Do you see that last chat? Someone was wondering, did glasses and loops start the selling? Maybe they're wondering if they're being sold.
Yeah, I will answer that question, but where's the question? How do I find it?
So do you have chat open or Q&A?
Let me just do that again, okay, just a second. You can see me right now, right?
Yep.
Okay, let me just chat. There's a chat button at the bottom, okay? I'm gonna click it, right?
Yep.
Oh, good, perfect. Yes, the glasses and the loops actually are being provided around the world. We actually have people contacting us, and then we're actually providing those glasses. The glass portion, of course, again, I have no financial interest. I do not make a single cent out of this. So the glasses portion, they would have to purchase, but the adapters we actually provide at no cost. So if they have any, but for some reason, if they cannot afford even the glasses, if they can contact us, and we may, I think we may be able to help those individuals. But yes, they're actually, the adapters is actually providing at no cost to the patient. So we're not selling them, we're providing it. Anything else? I know this type of talk was very different than the previous ones previous lectures, and this is very different than the lecture that I gave last time. And I hope this was informative, and I hope it was educational, and I hope you enjoyed it. And if you have any further comments, or if you come up with if you have any feedback, please you can contact Orbis. There's a way to Lawrence. There's a way to contact you, right?
Yep, and we have a few more chats if you see them in the chat.
I'm gonna do that. So you can contact Orbis, and I'll be happy to respond to any of the questions. And by the way, my email address, I'm gonna actually type it in. This is my email address, and you could actually address your questions directly to me. So here. Thank you. Okay, so the second question is, where do you order? And just email me, and I will forward the information directly to our optical shop. And how to contact to get the adapters. Okay, good. And what styles of frames does it fit? Actually, this particular frame actually fits to a spokes glasses, spokes. And they're actually, there's an online information that you can actually get. Dear Donny, thank you for, John, thank you. Thank you for creating inspiration. So it was a great surgical instruments. How to make 3D printers. Be able to test them in real patients. Yes, I was actually I was able to test them in real patients. It doesn't have any special coating because it's got it's a completely made of titanium, and it's the same material that actually the that other surgical instruments are made. So there's no paint. Yeah, good question. That is actually some of the problems that I'm actually having with some of my other inventions. We're actually working on special type of glasses, but it requires a certain glue. So we have to make sure that this glue is actually edible. So that's actually the limiting factor right now. Can you apply adapters to current loops? This adapter right here, yes. This is actually added on, but you actually most of the frames are actually most of the frames that we use. The surgical loops are mostly made out of titanium, so it's actually and you actually have to carve it just a little bit to fit this adapter in. But yes, it is doable. But you actually need special person who can actually make the adapter. But yes, it can be actually done. As a matter of fact, this is like exactly what we did. This is an adapter that we developed. Email is not seen on screen. So Lawrence, my email address is not seen. So can you share that?
Yep, I'll share that.
Okay, thank you. Does the glasses adapter work well with very heavy lenses? Yes, actually, it's actually most ideal for those patients with the very thick myopic or hyperopic corrections because it distributes the weight evenly, and it actually makes the glasses very light. So I would highly recommend it for those patients. Would that adapter personnel be in Nebraska? Yes. The person who actually makes this, his name is Mr. James Hermson, and he's just a wonderful guy. He was and the reason I was able to actually do a lot of these things is because I'm working with some amazing people here in Nebraska, in Omaha, and he's right here in Nebraska, but he can actually send these adapters to anywhere in the country or in the world, for that matter. And I'm pretty sure that if there's someone that we can help, we would love to reach out and help. Well, thank you very much for your time today. I look forward to one more question. I'm going to take one more question. Have these adapters been used on special needs frames like specs for us? Tracy, can you repeat that question? Like, which adapters are you referring to? So any model of 3D print, okay. So I'm going to go back to glass adapters for patients. Yes, this adapter for the patients with the plagiocephalies, and microcephaly, microtias, any type of deformities. This adapter can be made and can be adapted to any glasses, but it fits the best in this particular type of glasses called the spokes, which is available anywhere, and also it's available online. And then let me think. And also I just want to make sure that this adapter is actually, when they wear it, your hair can cover it very nicely, so it's almost invisible. You can't really see it. And also you can actually decorate it so that like it actually looks like a headband. Glass adapter. So any model of 3D printer that can, you know what? That's a great question. I'm going to tell you, the 3D printer is being advanced, and they're keep modifying it and making it better and better. And I think we're in the process of getting even a new 3D printer that costs more than my car. So I would not recommend any particular model of 3D printer at this point because it keeps on changing. It keeps on getting better and better because we want to be able to use metal for future 3D printing. So and with the current 3D printers, we don't have that capability. And also the types of materials, you're somewhat limited to. So, but I'm going to say that it's just continuing to get better and better. And with that technology, I think we can actually even be better with our creations and with our final products. Well, thank you very much. I hope let's see. The glass adapter for patient. Can you attach the lens part of the frame? No earpieces. I didn't understand that question. The glass adapters for patients. Can you attach the lens part of the frame? No earpieces. Oh, yes, yes. Tracy, yes. You don't need the frame. Actually, you don't need the frame at all. You can actually attach this directly to the lenses, and we actually have some of those models. That's right. And the reason we actually put this in there is that to make it look more like real glasses. But you don't need this temple at all. You can actually attach this directly to it, and it works just fine. As a matter of fact, that's what my friend, Mr. Hermson, that's actually what he wears. Well, thank you very much for your day, for sharing your wonderful morning or evening, and I hope you have a great day, and I look forward to seeing you again at the future Cybersight talk.